Hello again, everyone. I'm Dennis McCarthy with Upper Allegheny Health System and Olean General Hospital, welcoming you to another edition of Inside Olean General Hospital, a news and information program to help our viewers understand some of the great services offered here in Olean at Olean General. We're happy today because with us is our new neurologist at Olean General, Dr. Vijayante Balay. Welcome to Olean and welcome to our program.
Thank you, Dennis. Thank you.
How are you enjoying the community since you arrived?
Well, I'm really loving it. I came here by end of September last year, right in the midst of fall, and enjoying the nature, enjoying a very loving community here. And the doctors are great. And all my colleagues have been very welcoming to me.
We're so glad to have you. We're very, very excited to be able to offer neurology services to our patients. And I just want to start for a few minutes by explaining what is neurology? What does the practice mean, and what kinds of things happen with you and your patients?
Sure. Neurology deals with diseases or dysfunction of brain, spinal cord, nerve, and also muscles. So the common condition you must have come across patients with headache, memory impairment, tingling and numbness in hands, back pain, neck pain, seizures, of course. All these and other kind of conditions are evaluated and diagnosed by the neurologist.
How do people know that, maybe it's time for me to go see a neurologist? You know, sometimes people have a headache or they have some dizziness or something wrong with their eyes. Mm-hmm. What would be an indicator to say, you know, I really need to go see a doctor and probably a specialist? So what are the kinds of things you look for?
Sure. Many of these symptoms are common, and they're usually addressed by your primary care doctor. Some of these symptoms have a very common explanation. For example, low blood sugar can give rise to sense of lightheadedness. And the primary care doctor usually are able to address the symptoms which are for a short time or which are very common and simple. But if the symptoms become progressive and they are not responding to common treatment, that is the time the referral is made by the primary care doctor to go to the neurologist. So if you are suffering from symptoms which have been going on for quite some time, not responding to regular treatment, you can consult your primary care doctor if you actually need to see a neurologist.
I see. You also treat disease conditions, too, as a neurologist, you know, and I look at the dementia,
yes,
for instance, and peripheral nerve disease, which is kind of a strange thing. They call it peripheral neuropathy, and I'm not even sure what that means. So maybe you can help explain that.
Sure. Peripheral neuropathy is the diseases of peripheral nerves. The way our brain controls our muscles and gets information from our skin is by extending these wires. I call it, nerves are very similar to wires because they send the information back and forth. Due to age or as person's age advances, they may develop some kind of deficiencies. A lot of patients who have a diabetes, that also affects their nerves, and that results in dysfunction or pathology or diseases of these nerves, giving rise to symptoms such as tingling in the hands, burning in your feet, unsteadiness of gait. All these symptoms are suggestive of peripheral neuropathy.
How do you treat an issue like that? What are the options for patients?
Sure. So first step in evaluation is to make a correct diagnosis. We do EMG nerve conduction studies where we sample these nerves and look how they are conducting, how are they conducting the information efficiently, is there a muscles are showing a signs of denervation. Once we establish, with this study, EMG nerve conduction study, we establish the diagnosis. And then we look for what is the cause. And that is done by sending a set of blood tests. We look for if the patient has a prediabetes, do they have a vitamin deficiency? And once we establish the cause of this, then that can be adequately treated.
Is it safe to say that problems within the world of neurology become more pronounced or worse as people age? Is age a factor in all of this?
Absolutely. Every person starts losing some part of their nerve population or a neuronal population when they turn 20. So, but our brain is very efficient, so we still continue to function for a long time, and that is forming new connections. As we learn, we form new connections. But overall, as the age advances, there are a lot of conditions, neurological conditions that come up. For example, dementia, stroke, peripheral neuropathy, and neurodegenerative disorders like Parkinson's disease that are more common or more prevalent in an older population. So neurology is neurological help is more needed for the older population than the younger population.
Let's talk about dementia for a few minutes, just for a second or two.
Mm-hmm.
What is it that causes dementia, and actually physically what happens to people?
Sure. So some amount of cognitive deterioration, that's actually a bad word. We would say everybody experiences as they start aging, they're a little forgetful. They don't have a patience to read as much as they used to read, or any learning new things becomes difficult. So there is a normal age-related changes that happen. That is not dementia. Many times that is what is mistaken for dementia. Dementia is a disproportionate impairment in the cognitive abilities that affects your day-to-day life. Right. For example, somebody who has been driving a few months back cannot drive because they can't figure out how the car works, or they get lost. Those are concerning signs for dementia, and that requires a detailed evaluation to make a clinical diagnosis.
So it is natural for people to be forgetful.
Yes.
As time goes on,
yes.
And that may be a reflection of how busy they are and other things. But
true.
People shouldn't necessarily jump to a conclusion.
That's
to say, I forgot what I put in my coffee this morning, so maybe I better go see the doctor.
Absolutely,
okay.
That's very important. That every forgetfulness is not a dementia.
We also talk about, as a neurologist, you treat multiple sclerosis.
Yes.
How do you approach something like that with a patient?
Sure. Do you know that in the United States, the maximum population of MS cases are in Seattle and in Western New York? And we don't know whether it is the latitude or what's the cause of that. Is the vitamin deficiency, or there is a predisposition? But since I've come here, I have started seeing a lot of patients who already have a multiple sclerosis, or probably have, and it is not diagnosed. And that is one thing we want to start here, to have a center where we can coordinate their care and provide multiple treatment modalities available. Yeah.
So what other kinds of procedures do you do here in the office? Let's go through maybe not a normal day, because there probably isn't one. But,
yes. Yeah.
Kinds of patients that you're seeing, the treatments that we take care of here at Olean.
Sure. Before treatment, for a diagnostic, as I said, we do EMG and nerve conduction studies in the office. We also do EEG down at Olean General Hospital, but that service is available. We also arrange ambulatory EEG, like people come at home and do EEG, and then we get the feedback, the video and the EEG feedback of those patients. As far as treatment is concerned, we started doing for pain management. We started doing nerve injections, and some of these patients have reported great relief while they are in the hospital, while they are in the office. As soon as we treated patients, they got a dramatic pain relief, and that was very fulfilling for us as providers. So we're starting that. We are also starting a Botox program for migraine, and spasticity.
Explain Botox and how does that help? Well, most people think of Botox as a cosmetic way to look better, but this is a treatment for a headache.
Right.
How does that work?
Well, we don't know exactly how that works, but the part could be a lot of muscles around the head and the neck go into spasm, and they sort of facilitate or drive the migraine headache. And patients who have already been on 2 or 3 medications and still they continue to have more than 15 headaches per month have shown to have benefited by a Botox injection. That Botox therapy for migraine is FDA approved, and we inject in around 30 to 32 injections on muscles around head and neck, and the treatment is repeated every 3 months. And a lot of patients have a significant relief or reduction in their pain of migraine with that treatment. This is the treatment which we're going to offer here, and we are starting that now.
That's great. What else do you see coming up in terms of the kinds of things we want to do here?
We are soon going to start a spine clinic. A lot of patients have back pain and neck pain, and the causes are 100 different causes, but they just get treated like pain, either with pain medication, some get narcotic medication, and I think the real cause of their pain is not really addressed. Is it coming from muscle? Is it coming from bone? Is it coming from abdomen or somewhere else? So we are going to start a spine program, which is a multi-modality or multi-speciality program where we triage your neck pain or back pain and offer treatment, starting with a simple treatment and physical therapy, and if require, an injection. But I believe that only 10% of patients with neck or back pain may need surgery. And a lot of patients, 90% of the patients can be managed if we can get to the bottom of why they have pain and give them a proper treatment. When people think of back pain, they think of, oh my God, do I not going to need a surgery?
Yeah.
And that is not true. As I said, 90% of the cases can be treated conservatively. And if treated properly, even they may not require many medications also.
It's even better. It is. Did we miss anything here? I know we're going to talk about stroke in a minute, but is there anything else that we want to discuss in terms of the practice here?
We have covered a lot of grounds.
We did.
I can't imagine we covered so much.
We did, and this is a great program. Once again, we're going to talk some more, but thank you. We'll be back in a minute, and we're going to talk about stroke. Welcome again, everyone. I'm Dennis McCarthy with Upper Allegheny Health System and Olean General Hospital, continuing a conversation that we're having with Dr. Vijante Balay, the neurologist at Olean General and Foothills Medical Group. Thanks again for being with us. You know, we talked before about a lot of the issues neurology deals with, the kinds of things that you help people with. But the one thing that we didn't talk about that we want to spend some time on is something that's very, very important and a very big problem in the community, and that's stroke.
When we talk about stroke, what's usually mean is ischemic stroke. So ischemia is the reduction in the blood supply to the area of the brain. And that may happen because the artery supplied to the blood vessel may be blocked by a clot, either coming from the big artery like carotid or coming from the heart. And that causes death of the neurons in that part of the brain. So the function, what that part was subserving, let's say speech or giving motor power to the arm, that suffers. And that's how you get weakness or paralysis after stroke.
It's really robbing the brain of oxygen. Is that what the key is within the blood flow, right?
Absolutely. Yes. Okay. Yes. The other part of the other stroke is hemorrhage or a bleeding inside the brain. And it's very important to identify whether the stroke or an acute neurological dysfunction is caused by bleed or the loss of blood supply or ischemia, because the treatment are very different. If it is a bleed, then patient may require an evacuation of that hematoma. On the other hand, if it is ischemia, we may give a treatment to thin the blood or a clot buster medication to improve the blood supply. And if that happens, if that medication is by mistake given in a patient who had a bleed, it may actually worsen that bleed. So that distinction is made by a timely CT scan when the patient develops these symptoms.
It's important for people not to ignore signs and symptoms of a stroke, because that's what I'm told by doctors like you.
Yes.
Because the expression that I hear is time is brain.
Absolutely.
And like a heart attack, time is muscle. This is kind of the same idea, but up in the obviously the head area. Would a person necessarily know which kind of stroke they're experiencing from any symptoms? For instance, you said ischemic or hemorrhagic. Is there any way that they might know the difference, or is it just maybe the symptoms can be the same?
Symptoms can be same, and they cannot make a distinction. You rightly said that time is brain, and I actually would like to call it as a brain attack rather than stroke, because it conveys the same urgency when we say brain attack, just like we understand heart attack. Now, it is important from patients and the relative's point of view to understand the stroke symptoms and call 911, because we have what the therapy called a TPA, or an intravenous thrombolysis. If patient comes to the ED, the emergency department, early enough, within 3 hours we can administer a clot buster medicine, and that can remarkably improve patient's function by restoring the blood supply to that part. But that can happen only if patients identify the stroke symptoms and call 911 as soon as they happen. And the way to remember that is FAST. It is face, arm, speech, and time. So
face, arm, speech, and time. Explain the face.
Sure. So if your patient or if your relative suddenly you see there is something different, or patient may say, "Oh, my hand suddenly goes numb," there are 3 things you ask them to do. You ask them to smile, and if they say one side of the mouth is not, angle of the mouth is not going as up as the other side, that is the one sign of stroke. You ask them to raise their arm in front of them, and if one arm drifts down or does not come up, that's also they may have been having weakness. So that is the A
that's
for
the
arm.
The other one is
and the speech. And the speech, you ask them to say any word, repeat the phrase like, "The sky is blue in Cincinnati," or "Today is a sunny day." And if they stutter, if their speech is they're not able to repeat, they're not able, you don't understand what they're talking, that's also one of the sure sign of they're having stroke. So if you find any or all of this is the time to call. So that is the T, time, call them 911. The earliest from the onset of symptoms we can treat patients, the better is the outcome. So if you find this happens at middle of the night, don't wait till morning thinking that everything will improve. Call immediately and
get to the
911, come to the hospital, and only there we will do a CT scan to differentiate whether it's a hemorrhagic stroke or if it is an ischemic stroke, and the appropriate treatment can be given.
Is it, again, with age, stroke chances increase?
Mm-hmm.
What are some of the other contributing factors that might lead you to be more subject to having a stroke?
Absolutely. The usual risk factors of having stroke is there are common suspect: hypertension, uncontrolled hypertension, uncontrolled diabetes, are two big risk factors. Hypercholesteremia or hyperlipidemia is the other third major risk factor. Smoking is one of the big risk factors. It has been shown in a lot of data that if you control these are secondary risk factors, your chances of developing stroke during your lifetime significantly reduces.
So you have a chance to live a little better, kind of be a better person in terms of your own
by changing lifestyle modification, yes.
And it's much like heart disease, isn't it?
Absolutely.
It sounds like the same things. Control
Yes.
your diet, don't smoke, eat right, exercise, and all that. And in the end, you have probably a better chance. That's interesting information.
Right. The stroke is basically the disease of blood vessels. So all these lifestyle changes which we talked about, they affect blood vessels, if they are blood vessels of the heart and blood vessels of the brain. So when you control these factors which we spoke about, they will reduce your chances of stroke and heart attack.
There was one that I wanted to ask you about. We talked about the two kinds of strokes, but I've also heard people describing what they call a mini stroke or a TIA. Mm-hmm. What is that?
A TIA or a mini stroke is patients develop transient dysfunction. Like the symptoms we talked about, that there's a facial droop or their arm drops, but that lasts for 10-15 minutes and then it recovers, or lasts for half an hour, then it recovers. And you have to consider TIA as like a warning attacks. They herald something, a big stroke, which is coming later. So usually if it recovers, patients say, oh, now I'm fine, I don't need to go to the doctor. But actually it's a warning given to you, and you should come to the doctor, to the emergency department,
right.
And so that we can address what is causing that stroke and prevent it, causing that TIA, and prevent the stroke from happening just in time.
And I guess that's, I suppose it's a little bit of I don't want to call it a blessing, but at least you've got a chance. Somebody's
Yes.
waving a flag in front of you and saying,
yes,
don't ignore this. Make sure you get, what else did we need to talk about in terms of stroke and neurology? What did we miss?
I think we covered.
I think we did too.
Yeah, we covered a lot.
Well, thank you for being with us. If you need more information on our stroke program here at Olean General, the information will be coming up on your screen in a moment. Again, with all of this, take care of yourself. And what we talked about in terms of stroke and some of the other things, don't fool around. If you've got symptoms and you've got problems, don't be stubborn. Don't ignore them. Get to the hospital and get some care right away. Thank you, Dr. Belay, for being with us. And thank you for being with us tonight.